In terms of whose responsibility is it organisationally, well, it's everyone's responsibility, and that's an easy answer. We are making some changes, pretty fundamental changes they appear, to the public health system to give local authorities more of a role, but they always did have a role, and the health service has a role, government has a role, and of course individuals too have a role. So it's easy to say public health is everybody's business. It's a sort of phrase that trips off the tongue. Making it happen in a coordinated way so that people have their health improved and protected and have the health services that meet their needs is highly complex. We've been much more focused on health inequalities over the last decade than we were in the earlier part of my career. We have been much clearer on what are the major causes of those inequalities, and some of them are the things that we knew about but were not putting enough focus on. So cardiovascular disease and the effect it has on mortality and morbidity is a major issue, and we've put a huge amount of energy in the health service to improving outcomes for people in that. However, there is more to it than that, and those health inequalities, the Marmot report has shown us that they're entrenched from very, very early life. And there are some signal graphs in Marmot that demonstrate how children who start life in a deprived part of the population never catch up in terms of their health in general. So I think the next phase of the big task around health inequalities is to get right down to the root, rather than picking off the diseases that are taking people at this top end, death, and start at birth and start thinking, how do we make sure that these children under the age of 5 in particular get the very, very best start, so that they don't go through life with lead boots on around their opportunities for getting good health.